We are continuing discussing the topic of regeneration, and today we will talk about cardiovascular within the framework of diseases of the cardiovascular system and nephrosclerosis within the framework of kidney diseases. On this slide you can see the most significant diseases of the cardiovascular system, including atherosclerosis, arterial hypertension, and ischemic heart disease. Atherosclerosis is characterized by intimal lesions called atheromas or atheromatous or atherosclerotic plugs that impinge on the vascular lumen and can rupture to cause sudden occlusion. It underlies the pathogenesis of coronary and peripheral vascular disease and causes more morbidity and mortality in the Western world than any other disorder. Atheromatous plugs are raised lesions composed of soft, friable lipid cores, mainly cholesterol and cholesterol esters with necrotic debris covered by fibrous caps. As they enlarge, atherosclerotic plugs may mechanically obstruct vascular lumina, leading to stenosis. Of greater concern, however, atherosclerotic plugs also are prone to rupture, an event that may result in thrombosis and sudden occlusion of the vessel. The thickness of the intimal lesion also may be sufficient to impede the perfusion of the underlying media, which may be weakened by ischemia and by changes in the extracellular matrix caused by subsequent inflammation. Together, these two factors weaken the media, setting the stage for the formation of aneurysms. With better treatment of infectious disorders and increased access to Western dietary behaviors, atherosclerosis is also becoming increasingly prevalent in developing countries. Because coronary artery disease is an important manifestation of atherosclerosis, epidemiologic data related to atherosclerosis-related mortality typically reflect deaths caused by ischemic heart disease. Indeed, myocardial infarction is responsible for roughly one quarter of all deaths in the United States. Atherosclerosis is virtually ubiquitous among most developed nations, with prevalence increasing at an alarming pace in developing countries. The mortality rate for ischemic heart disease in the United States is among the highest in the world, approximately 5 times higher than that in Japan. However, ischemic heart disease is increasing in Japan, where it is now the second leading cause of death. Furthermore, Japanese immigrants who come to the United States and adopt American lifestyles and dietary customs acquire the same atherosclerosis risk as US-born individuals, emphasizing the important etiologic role of environmental factors. The prevalence and severity of atherosclerosis and ischemic heart disease have been correlated with a number of risk factors in several prospective analyses, including the landmark Framingham Heart Study. Some of these risk factors are constitutional and therefore less controllable, but others are acquired or related to modifiable behaviors, as you can see in the table. These risk factors have roughly multiplicative effects. Therefore, 2 factors increase the risk of myocardial infarction approximately 4-fold, and 3 increase the rate by a factor of 7, including hyperlipidemia, hypertension, and smoking. So genetics is one of constitutional, non-modifiable risk factors. The family history is the most important independent risk factor for atherosclerosis. Certain Mendelian disorders are strongly associated with atherosclerosis, including familial hypercholesterolemia, but these account for only a small percentage of cases. Most familial risk is related to multifactorial traits that go hand in hand with atherosclerosis, including hypertension and diabetes. Age is another non-modifiable factor, and atherosclerosis usually remains clinically silent until lesions reach a critical threshold in middle age or later. Therefore, the incidence of myocardial infarction increases fivefold between 40 and 60 years of age. Death rates from ischemic heart disease continue to rise with each successive decade. Gender is another factor that cannot be modified. All other factors being equal, premenopausal women are relatively protected against atherosclerosis compared with age-matched men. Therefore, myocardial infarction and other complications of atherosclerosis are uncommon in premenopausal women in the absence of other predisposing factors, such as diabetes, hyperlipidemia, or severe hypertension. After menopause, however, the incidence of atherosclerosis-related disease increases and can even exceed that in men. Although a salutary effect of estrogen has long been proposed to explain this gender difference, clinical trials have shown no benefit of hormonal therapy for prevention of vascular disease. Indeed, estrogen replacement after 65 years of age appears to actually increase cardiovascular risk. In addition to atherosclerosis, gender also influences other factors that can affect outcome in patients with ischemic heart disease, such as hemostasis, infarct healing, and myocardial remodeling. Hyperlipidemia is a modifiable risk factor, and more specifically, hypercholesterolemia is a major factor for development of atherosclerosis and is sufficient to induce lesions in the absence of other risk factors. The main cholesterol component associated with increased risk is low-density lipoprotein cholesterol, or so-called quote-unquote bad cholesterol. Low-density lipoprotein distributes cholesterol to peripheral tissues. By contrast, high-density lipoprotein cholesterol, so-called good cholesterol, mobilizes cholesterol from developing and existing vascular plaques and transports it to the liver for biliary excretion. Consequently, high levels of high-density lipoprotein correlate with reduced risk. Recognition of this relationship has spurred the development of dietary and pharmacologic interventions that lower total serum cholesterol or low-density lipoprotein and or raise serum high-density lipoprotein as follows. High dietary intake of cholesterol and saturated fats present in egg yolks, animal fats, and butter raise plasma cholesterol levels. Conversely, diets low in cholesterol and containing higher ratios of polyunsaturated fats lower plasma cholesterol levels. Omega-3 fatty acids abundant in fish oils are beneficial, whereas trans-unsaturated fats produced by artificial hydrogenation of polyunsaturated oils used in baked goods and margarine adversely affect cholesterol profiles. Exercise and moderate consumption of ethanol raise high-density lipoprotein levels, whereas obesity and smoking lower them. Statins are a widely used class of drugs that lower circulating cholesterol levels by inhibiting hydroxymethyl glutaryl coenzyme A reductase, the rate-limiting enzyme in hepatic cholesterol biosynthesis. Hypertension is another major risk factor for development of atherosclerosis. On its own, hypertension can increase the risk for ischemic heart disease by approximately 60%. Hypertension also is the major cause of left ventricular hypertrophy, which also can contribute to myocardial ischemia. Cigarette smoking is a well-established risk factor in men and probably accounts for the increasing incidence and severity of atherosclerosis in women. Prolonged smoking of one or more packs of cigarettes per day over the years doubles the rate of ischemic heart disease-related mortality, while smoking cessation reduces the risk. Diabetes mellitus is associated with raised circulating cholesterol levels and markedly increases the risk for atherosclerosis. Other factors being equal, the incidence of myocardial infarction is twice as high in diabetics as in non-diabetics. In addition, this disorder is associated with an increased risk for stroke and a 100-fold increase in atherosclerosis-induced gangrene of the lower extremities. The currently held view of pathogenesis is embodied in the response to injury hypothesis. This model views atherosclerosis as a chronic inflammatory response of the arterial wall to endothelial injury. Lesion progression involves interaction of modified lipoproteins, monocyte-derived macrophages, T lymphocytes, and the cellular constituents of the arterial wall. According to the model on the slide, atherosclerosis results from the following pathogenic events: endothelial cell injury and resultant endothelial dysfunction, leading to increased permeability, leukocyte adhesion, and thrombosis. Accumulation of lipoproteins, mainly oxidized low-density lipoprotein and cholesterol crystals in the vessel wall. Platelet adhesion, monocyte adhesion to the endothelium, migration into the intima, and differentiation into macrophages and foam cells. Lipid accumulation within macrophages, which respond by releasing inflammatory cytokines. Smooth muscle cells recruitment due to factors released from activated platelets, macrophages, and vascular wall cells. Smooth muscle cell proliferation and extracellular matrix production that will be discussed in some details later on. Endothelial cell injury is the cornerstone of the response to injury hypothesis. Endothelial cell loss due to any kind of injury induced experimentally or mechanically, hemodynamic forces, immune complex deposition, irradiation, or chemicals, all that results in intimal thickening. In the presence of high lipid diets, typical atheromas ensue. However, early human atherosclerotic lesions begin at sites of intact but dysfunctional endothelium. These dysfunctional endothelial cells exhibit increased permeability, enhanced leukocyte adhesion, and altered gene suppression, all of which may contribute to the development of atherosclerosis. Suspected triggers of early atheromatous lesions include hypertension, hyperlipidemia, toxins from cigarette smoke, and homocystinemia. Inflammatory cytokines, like tumor necrosis factor, also stimulate pro-atherogenic patterns of endothelial cell gene expression. Nevertheless, the two most important causes of endothelial dysfunction are hemodynamic disturbances and hypercholesterolemia. The importance of hemodynamic factors in atherogenesis is illustrated by observation that plugs tend to occur at the ostia of exiting vessels, at branch points, and along the posterior wall of the abdominal aorta, where there is turbulent blood flow. In vitro studies further demonstrate that non-turbulent laminar flow leads to the induction of endothelial genes whose products protect against atherosclerosis. Such atheroprotective genes may explain the non-random localization of early atherosclerotic lesions. Lipids typically are transported in the bloodstream bound to specific apoproteins, forming lipoprotein complexes. These lipoproteinemias can result from mutations in genes that encode apoproteins or lipoprotein receptors, or from disorders that derange lipid metabolism, like nephrotic syndrome, alcoholism, hypothyroidism, and diabetes mellitus. Common lipoprotein abnormalities in the general population include increased low-density lipoprotein cholesterol levels, decreased high-density lipoprotein cholesterol levels, and increased levels of lipoproteins. Several lines of evidence implicate hypercholesterolemia in atherogenesis. The dominant lipids in atheromatous plugs are cholesterol and cholesterol esters. Genetic defects in lipoprotein uptake and metabolism that cause hyperlipoproteinemia are associated with accelerated atherosclerosis. Therefore, homozygous familial hypercholesterolemia caused by defective low-density lipoprotein receptors and inadequate hepatic low-density lipoprotein can lead to myocardial infarction by 20 years of age. Other genetic or acquired disorders like diabetes mellitus, hypothyroidism that cause hypercholesterolemia lead to premature atherosclerosis. Epidemiologic analysis demonstrate a significant correlation between the levels of total plasma cholesterol and low-density lipoprotein and the severity of atherosclerosis. Lowering serum cholesterol by diet or drugs slows the rate of progression of atherosclerosis, causes regression of some plugs, and reduces the risk for cardiovascular events. Inflammation contributes to the initiation, progression, and complications of atherosclerotic lesions. Normal vessels do not bind inflammatory cells. Early in atherogenesis, however, dysfunctional endothelial cells express adhesion molecules that promote leukocyte adhesion, in particular monocytes and T cells, which migrate into the intima under the influence of locally produced chemokines. Monocytes differentiate into macrophages and avidly engulf lipoproteins, including oxidized low-density lipoprotein and small cholesterol crystals. Cholesterol crystals appear to be particularly important instigators of inflammation through activation of the inflammasome and subsequent release of interleukin-1. Activated macrophages also produce toxic oxygen species that drive low-density lipoprotein oxidation and elaborate growth factors that stimulate smooth muscle cell proliferation. T lymphocytes recruited to the intima interact with macrophages and also contribute to chronic inflammation. It is not clear whether the T cells are responding to specific antigens or are non-specifically activated by the local inflammatory milieu. Nevertheless, activated T cells in the growing intimal lesions elaborate inflammatory cytokines which stimulate macrophages, endothelial cells, and smooth muscle cells. As a consequence of the chronic inflammatory state, activated leukocytes and vascular wall cells release growth factors that promote smooth muscle cell proliferation and matrix synthesis. Smooth muscle cells proliferation and extracellular matrix deposition lead to conversion of the earliest lesion, a fatty streak, into a mature atheroma, thus contributing to the progressive growth of atherosclerotic lesions shown in the picture. Several growth factors are implicated in smooth muscle cell proliferation and matrix synthesis, including platelet-derived growth factor, released by locally adherent platelets, macrophages, endothelial cells, and smooth muscle cells, fibroblast growth factor, and tissue growth factor. The recruited smooth muscle cells synthesize extracellular matrix, which stabilizes atherosclerotic plugs. However, activated inflammatory cells in atheromas also can cause intimal smooth muscle cells apoptosis and breakdown of matrix, leading to the development of unstable plugs. The development of atherosclerosis tends to follow a series of morphologic changes. Fatty streaks begin as minute yellow, flat macules that coalesce into elongated lesions 1 cm or more in length. They are composed of lipid-filled foamy macrophages but are only minimally raised and do not cause any significant flow disturbance. Fatty streaks can appear in the aortas of infants younger than 1 year of age and are present in virtually all children older than 10 years of age, regardless of genetic, clinical, or dietary risk factors. Not all fatty streaks are destined to progress to atherosclerotic plaques. Nevertheless, it is notable that coronary fatty streaks form during adolescence at the same anatomic sites that are prone to plaques later in life. The key feature of atherosclerotic plaque are intimal thickening and lipid accumulation, shown on the picture on the left. Atheromatous plugs are white to yellow raised lesions. They range from 0.3 to 1.5 centimeters in diameter, but can coalesce to form larger masses. Thrombus superimposed on ulcerated plugs imparts a red-brown color. Atherosclerotic plugs are patchy, usually involving only a portion of any given arterial wall. On cross-section, therefore, the lesions appear eccentric. The focal nature of atherosclerotic lesions may be related to the vagaries of vascular hemodynamics. Local flow disturbances, such as turbulence at branch points, make certain parts of a vessel wall especially susceptible to plaque formation. In descending order of severity, atherosclerosis involves the infrarenal abdominal aorta, the coronary arteries, the popliteal arteries, the internal carotid arteries, and the vessels of the circle of Willis. Even in the same patient, atherosclerosis typically is more severe in the abdominal aorta than in the thoracic aorta. Vessels of the upper extremities usually are spared, as are the mesenteric and renal arteries, except at the ostia. It is important to note that the severity of atherosclerosis in one vascular location does not necessarily predict its severity in another. Nevertheless, any given patient tends to show comparable severity of disease throughout his or her vasculature. Finally, in any given vessel, lesions at various stages of severity often coexist. Atherosclerotic plaques have three principal components: cells including smooth muscle cells, macrophages, and T cells, shown by the black star; extracellular matrix, including collagen, elastic fibers, and proteoglycans, shown by the red star; and intracellular and extracellular lipid, shown by yellow star. The proportion and configuration of each component varies from lesion to lesion. Most commonly, plaques have a superficial fibrous cap composed of smooth muscle cells and relatively dense collagen. Where the cap meets the vessel wall is a more cellular area containing macrophages, T cells, and smooth muscle cells. Deep to the fibrous cap is a necrotic core containing lipid, primarily cholesterol and cholesterol esters, as well as necrotic debris, lipid-laden macrophages, and smooth muscle cells, or known also as foam cells, fibrin, variably organized thrombus, and other plasma proteins. The extracellular cholesterol frequently takes the forms of crystalline aggregates that are washed out during routine tissue processing, leaving behind empty cholesterol clefts. The periphery of the lesions show neovascularization, proliferating small blood vessels, shown on the picture by black arrows on the right picture. The media deep to the plaque may be attenuated and exhibit fibrosis secondary to smooth muscle atrophy and loss. Typical atheromas contain relatively abundant lipid, but some so-called fibrous plaques are composed almost exclusively of smooth muscle cells and fibrous tissue. Atheromas also often undergo calcification, shown by the green stars. Atherosclerotic plaques are susceptible to several clinically important changes: rupture, ulceration, or erosion of the luminal surface, shown on the picture on the left. These erosions and ruptures and ulceration of atheromatous plaques expose highly thrombogenic substances and induces thrombus formation, shown on the picture on the right. Thrombi may partially or completely occlude the lumen, leading to tissue ischemia. If the patient survives, thrombi become organized and incorporated into the growing plaque. Hemorrhage can be caused by rupture of the overlying fibrous cap, as shown on the picture, or of the thin-walled vessels in the area of neovascularization. The resulting hematoma may cause rapid plaque expansion or plaque rupture. Atheroembolism. A ruptured plug can discharge debris into the blood, producing microemboli composed of plug contents, shown on the picture on the left by star. Aneurysm formation is shown on the picture on the right. Atherosclerosis-induced pressure or ischemic atrophy of the underlying media with loss of elastic tissue causes structural weakening that can lead to aneurysmal dilation and rupture. Large elastic arteries like aortic carotid artery and iliac artery, and large and medium-sized muscular arteries like coronary, renal, and popliteal arteries are the vessels most commonly involved by atherosclerosis. Accordingly, atherosclerosis is most likely to present with signs and symptoms related to ischemia of the heart, brain, kidneys, and lower extremities. Myocardial infarction or heart attack, cerebral infarction or stroke, aortic aneurysm, and peripheral vascular disease or gangrene of extremities are the major clinical consequences of atherosclerosis. The natural history, morphologic features, and main pathogenic events are schematized in the picture on the slide. The principal pathophysiologic outcome stemming from atherosclerotic lesions vary depending on the size of the affected vessel, the size and stability of the plugs, and the degree to which plugs disrupt the vessel wall. We will discuss these features that are typically responsible for the clinical manifestation. At early stages, remodeling of the media tends to preserve the liminal diameter by increasing the overall vessel circumference. Owing to limits on remodeling, however, eventually the expanding atheroma may impinge on blood flow. Although this most commonly happens as a consequence of acute plug change, it can also occur gradually, with critical stenosis being the tipping point at which chronic occlusion limits flow so severely that tissue demand exceeds supply. In the coronary artery and other circulations, this typically occurs when the vessel is approximately 70% occluded. At rest, affected patients have adequate cardiac perfusion, but with even modest exertion, demand exceeds supply, and chest pain develops because of cardiac ischemia. It's known as stable angina. The toll of chronic arterial hyperfusion due to atherosclerosis in various vascular beds includes bowel ischemia, sudden cardiac death, chronic HD, ischemic encephalopathy, and intermittent claudication or ischemic leg pain. Ischemic heart disease is a broad term encompassing several closely related syndromes caused by myocardial ischemia, an imbalance between cardiac blood supply and myocardial oxygen and nutritional requirements. Since cardiac myocytes generate energy almost exclusively through mitochondrial oxidative phosphorylation, cardiac function is strictly dependent upon the continuous flow of oxygenated blood through the coronary arteries. Despite dramatic improvements in therapy in the past quarter century, ischemic heart disease in its various forms remains as the leading cause of mortality in the developed countries, accounting for 7.5 million deaths worldwide each year. In more than 90% of cases, ischemic heart disease is a consequence of reduced coronary blood flow, secondary to obstructive atherosclerotic vascular disease. Therefore, unless otherwise specified, ischemic heart disease usually is synonymous with coronary artery disease. In most cases, the various syndromes of ischemic heart disease are consequences of coronary atherosclerosis that has been gradually progressing for decades, beginning even in childhood or adolescence. The manifestations of ischemic heart disease are a direct consequence of insufficient blood supply to the heart. The clinical presentation may include one or more of the cardiac syndromes. Angina pectoris, literally chest pain. Ischemia induces pain but is insufficient to cause myocyte death. Angina can be stable, occurring predictably at certain level of exertion, or can be caused by vessel spasm, princemetal angina, or can be unstable, occurring with progressively less exertion and or even at rest. Myocardial infarction. This occurs when the severity or duration of ischemia is sufficient to cause cardiomyocyte death. Chronic ischemic heart disease with chronic heart failure. This progressive cardiac decompensation, which occurs after acute myocardial infarction or secondary to accumulated small ischemic insults, eventually precipitates mechanical pump failure. Sudden cardiac death. This can occur as a consequence of tissue damage from myocardial infarction, but most commonly results from a lethal arrhythmia without myocyte necrosis. More than 700,000 Americans experience a myocardial infarction each year, and roughly half of those affected die. As troubling as this toll is, it represents a spectacular advance. Since peaking in 1963, the mortality related to ischemic heart disease in the US has declined by 50%. The improvement is largely attributed to interventions that have diminished cardiac risk factors, behaviors or conditions that promote atherosclerosis, in particular smoking cessation programs, hypertension and diabetes treatment, and use of cholesterol-lowering agents. To a lesser extent, diagnostic and therapeutic advances also have contributed. These include aspirin prophylaxis, beta arrhythmia control, establishment of coronary care units, thrombolysis for myocardial infarction, angioplasty and endovascular stenting, and coronary artery bypass graft surgery. Maintaining this downward trend in mortality will be particularly challenging given the predicted longevity of baby boomers, as well as the epidemic of obesity that is sweeping the United States and other parts of the world. Myocardial infarction, also commonly referred to as a heart attack, is necrosis of the heart muscle resulting from ischemia. The major underlying cause of ischemic heart disease is atherosclerosis. While myocardial infarctions can occur at virtually any age, the frequency rises progressively with aging and with increasing risk factors for atherosclerosis. Nevertheless, approximately 10% of myocardial infarctions occur before 40 years of age and 45% occur before 65 years of age. Blacks and whites are equally affected. Men are at greater risk than women, although the gap progressively narrows with age. In general, women tend to be protected against myocardial infarction during their reproductive years. However, menopause, with declining estrogen production, is associated with exacerbation of coronary artery disease, and ischemic heart disease is the most common cause of death in older adult women. Loss of blood supply has profound functional, biochemical, and morphologic consequences for the myocardium. Within seconds of vascular obstruction, aerobic metabolism ceases, leading to a drop in adenosine triphosphate and accumulation of potentially noxious metabolites like lactic acid in the cardiac myocytes. The functional consequence is a rapid loss of contractility, occurring within a minute or so of the onset of ischemia. Ultrastructural changes, including myofibrillar relaxation, glycogen depletion, cellular and mitochondrial swelling, are also observed. These early changes are reversible. Only prolonged ischemia lasting at least 20 to 40 minutes causes a reversible change and coagulative necrosis of myocytes. With longer periods of ischemia, vessel injury ensues, leading to superimposed microvascular thrombosis. Based on the size of the involved vessel and the degree of collateral circulation, myocardial infarcts may take one of the following patterns. Transmural infarctions involve the full thickness of the ventricle and are caused by epicardial vessel occlusion through a combination of chronic atherosclerosis and acute thrombosis. Subendocardial infarctions are involved the inner third of the myocardium, the subendocardial region, is the most vulnerable to hyperperfusion and hypoxia. This pattern also can occur when an occlusive thrombus lyses before a full-thickness infarction can develop. Microscopic infarcts occur in the setting of small vessel occlusions. This can occur in the setting of vasculitis, embolization of valve vegetations, or mural thrombi, or vessel spasm due to elevated catecholamines, as may occur in extreme emotional stress with certain tumors or as consequence of cocaine use. Nearly all transmural infarcts, involving 50 or more % of the ventricle thickness, affect at least a portion of the left ventricle and or interventricular septum. The gross and microscopic appearance of the myocardial infarct depends on the age of the injury. Areas of damage progress through a highly characteristic sequence of morphologic changes from coagulative necrosis to acute and then chronic inflammation to fibrosis. Myocardial necrosis proceeds invariably to scar formation without any significant regeneration. Studies looking at whether tissue stem cells can be used to regenerate functional myocardium are ongoing but have yet to bear fruit. Gross and microscopic recognitions of very recent myocardial infarctions can be challenges, particularly when death occurs within a few hours. Myocardial infarction less than 12 hours old usually are not grossly apparent. However, infarcts more than 3 hours old can be visualized by exposing myocardium to vital stains such as triphenyl tetrazolium chloride, a substrate for lactate dehydrogenase. Because this enzyme is depleted in the area of ischemic necrosis, the infarcted area is stained in dark brown color. By 12 to 24 hours after myocardial infarction, an infarct usually can be grossly identified by a red-blue discoloration caused by stagnated, trapped blood. Thereafter, infarcts become progressively better delineated as a soft yellow tan areas. By 10 to 14 days, infarcts are rimmed by hyperemic, highly vascularized granulation tissue. Over the succeeding weeks, the infarcted tissue evolves to a fibrous scar. The microscopic appearance also undergoes a characteristic sequence of changes. Typical feature of coagulative necrosis shown by the star become detectable within 4 to 12 hours of infarction. Wavy fibers shown by the arrow also can present at the edges of an infarct. This reflects the stretching and buckling of non-contractile dead fibers. Sublethal ischemia can also induce intracellular myocyte vacuolization. Such myocytes are viable but frequently contract poorly. Necrotic myocardium elicits acute inflammation, typically most prominent 1 to 3 days after myocardial infarction. On the left picture, you see dense neutrophilic infiltrate in the area of a 2 to 3 day old infarction. This is followed by a wave of macrophages shown on the right picture by arrows that remove necrotic myocytes and neutrophil fragments, and this is more pronounced at 5 to 10 days after myocardial infarction. The infarcted zone is progressively replaced by granulation tissue shown on the picture, most prominent 1 to 2 weeks after myocardial infarction, and this in turn forms the provisional scaffolding upon which dense collagenous scar forms. In most instances, scarring, shown on the picture by arrows, is well advanced by the end of the 6th week, but the efficiency of repair depends on the size of the original lesion and the ability of the host tissues to heal. Healing requires the migration of inflammatory cells and ingrowth of new vessels from the infarction margins. And myocardial infarction heals from its borders toward the center, and a large infarction may not heal as fast or as completely as a small one. Moreover, malnutrition, poor vasculature, or exogenous anti-inflammatory steroids can impede infarction scarring. Once a myocardial infarction is completely healed, it is impossible to distinguish its age, whether present for 8 weeks or 10 years. Fibrous scar look the same. Atherosclerosis refers to sclerosis of small renal arteries and arterioles that are strongly associated with hypertension. The characteristic morphologic alterations of the small arterioles are called hyaline arteriosclerosis, while the arteries show fibrous, intimal, and medial thickening, often resulting in luminal narrowing. The vascular changes cause ischemia, which leads to various combinations of interstitial fibrosis, tubular atrophy, and focal global glomerulosclerosis. Some degree of nephrosclerosis, albeit mild, is present in many individuals older than 60 years of age. The frequency and severity of the lesions are increased at any age when hypertension or diabetes are present. Of note, many renal diseases cause hypertension, which in turn is associated with atherosclerosis. Therefore, this renal lesion often is superimposed on the primary kidney disease. The arterial lesions associated with hypertension are the result mainly of endothelial dysfunction and platelet activation. Two processes participate in the arterial lesions of nephrosclerosis: medial and intimal thickening, shown by the yellow arrow on the left picture, as a response to hemodynamic changes, aging, genetic defects, or some combination of those. Hyalinization of arterial walls, shown by the arrow on the right picture, caused by extravasation of plasma proteins through injured endothelium and by increased deposition of basement membrane matrix. Grossly, the kidneys are symmetrically atrophic, as shown on the picture on the left. Typically, the renal surface shows diffuse, fine granularity that resembles grain leather. Microscopically, the most prominent change is hyaline thickening of the walls of the arterioles, known as hyaline arteriosclerosis, shown on the picture on the right. This appears as homogeneous, pink hyaline thickening at the expense of the vessel lumina with loss of underlying cellular detail, shown on the picture by yellow arrows. The narrowing of the lumen results in markedly decreased blood flow through the affected vessels with consequent ischemia and renal atrophy. In advanced cases of arterial-nephrosclerosis, the glomerular tufts may become sclerosed, as on the picture on the right, shown by the red arrow. Diffuse tubular atrophy and interstitial fibrosis, shown by the star, are present, but inflammatory infiltrates are absent or scant. The larger blood vessels, intralobal or arcuate arteries, show intimal thickening with replication of internal elastic lamina, along with fibrous thickening of the medium, fibroelastic hyperplasia. This renal lesion alone rarely causes damage severe enough to produce renal failure, except in individuals from some possibly genetically susceptible groups such as African Americans, in whom it may lead to uremia and death. However, all patients usually show some functional impairment, such as loss of concentrating ability or a variably diminished glomerular filtration rate. A mild degree of proteinuria is a frequent finding. Malignant hypertension, defined as blood pressure usually greater than 200 over 120 millimeters, is far less common in the United States than essential hypertension and occurs in only about 5% of hypertensive individuals. It may rise de novo, or it may appear suddenly in an individual who had mild hypertension. The prevalence of malignant hypertension is high in developing countries. It may present with severe acute kidney injury, shown on the left picture, and renal failure. Renal changes are confined to the vasculature and may include thrombotic microangiopathy, shown on the picture on the right. The renal changes are related to hypertension and the reactions to it. Injury resulting from long-standing hypertension causes increased permeability of the vessels to fibrinogen and other plasma proteins, endothelial injury, and platelet deposition. This leads to the appearance of fibrinoid necrosis of arterioles and small arteries in intravascular thrombosis. Mitogenic factors from platelets, like platelet-derived growth factor and plasma, cause intimal hyperplasia of vessels, resulting in hyperplastic atherosclerosis. Because of the luminal narrowing, the kidneys become markedly ischemic, which leads to further elevation of blood pressure via the renin-angiotensin system. The kidney may be normal in size or shrunken depending on the duration and severity of the hypertensive disease. Small pinpoint petechial hemorrhages may appear on the cortical surface from rupture of arterioles or glomerular capillaries, giving the kidney a peculiar flea-bitten appearance. Damage to the small vessels is manifested as fibrinoid necrosis of the arterioles, shown by the black arrow on the left. The vessel walls show homogeneous granular eosinophilic appearance masking underlying detail. In the interlobular arteries and larger arterioles, proliferation of intimal cells after acute injury produces an onion skin appearance, shown on the picture on the right. This name is derived from the concentric arrangements of cells whose origin is believed to be intimal smooth muscle. Although this issue has not been finally settled, this lesion, called hyperplastic atherosclerosis, causes marked narrowing of arterioles and small arteries to the point of total obliteration. Necrosis also may involve glomeruli, with microthrombi within the glomeruli as well as necrotic arterioles. Similar lesions are seen in individuals with acute thrombic microangiopathies and in patients with scleroderma in renal crisis. The full-blown syndrome of malignant hypertension is characterized by papilledema, encephalopathy, cardiovascular abnormalities, and renal failure. Most often, the early symptoms are related to increased intracranial pressure and include headache, nausea, vomiting, and visual impairment, particularly the development of scotomas or spots before the eyes. At the onset of rapidly mounting blood pressure, there is marked proteinuria and microscopic or sometimes macroscopic hematuria, but no significant alteration in renal function. However, soon acute kidney injury develops. The syndrome represents a true medical emergency that requires prompt and aggressive antihypertensive therapy before irreversible renal lesions develop. About 50% of patients survive at least 5 years. 90% of deaths are caused by uremia, and the other 10% are caused by cerebral hemorrhage or cardiac failure. Other group of diseases involve the interstitium are diseases characterized by inflammatory involvement of the tubules and interstitium, and ischemic or toxic tubular injury leading to acute tubular injury and the clinical syndrome of acute kidney injury. We will shortly discuss tubular interstitial nephritis. The glomeruli may be spared altogether or affected only late in the course. In cases of tubular interstitial nephritis caused by bacterial infection, the renal pelvis is prominently involved, hence the more descriptive term pyelonephritis, from pyelo, meaning pelvis. The term interstitial nephritis generally is reserved for cases of tubular interstitial nephritis that are non-bacterial in origin. This includes tubular injury resulting from drugs, metabolic disorders such as hyperkalemia, irradiation, viral infections, and immune reactions. On the basis of clinical features and the character of the inflammatory exudate, tubular interstitial nephritis can be divided into acute and chronic categories. We will briefly look at chronic pyelonephritis and reflux nephropathy on the next slides. Chronic pyelonephritis is a clinical pathological entity in which interstitial inflammation and scarring of the renal parenchyma are associated with grossly visible scarring and deformity of the pelvic calyceal system in patients with a history of urinary tract infection. Chronic pyelonephritis is an important cause of chronic kidney disease. It can be divided into two forms: chronic obstructive pyelonephritis and chronic reflux-associated pyelonephritis. Chronic obstructive pyelonephritis is conditioned by obstruction and as a result of the infection. Recurrent infections superimposed on diffuse or localized obstructive lesions lead to recurrent bouts of renal inflammation and scarring, which eventually cause chronic pyelonephritis. The disease can be bilateral, as with congenital anomalies of the urethra, or unilateral, such as occurs with calculi and unilateral obstructive lesions of urethra. Chronic reflux-associated pyelonephritis is the most common cause of chronic pyelonephritis. It results from superimposition of a urinary tract infection on congenital vesicoureteral reflux and intrarenal reflux. Both of the reflux and the attendant renal damage may be unilateral or bilateral, the latter potentially leading to chronic renal insufficiency. One or both kidneys may be involved, either diffusely or in patches. Even when involvement is bilateral, the kidneys are not equally damaged and therefore are not equally contracted. This uneven scarring is useful in differentiating chronic pyelonephritis from the more symmetrically contracted kidneys associated with vascular sclerosis and chronic glomerulonephritis. The hallmark of chronic pyelonephritis is scarring involving the pelvis and calyces, or both, leading to papillary blunting and marked calyceal deformities. The microscopic changes are largely nonspecific, and similar alterations may be seen with other chronic tubular interstitial disorders such as analgesic nephropathy. The parenchyma shows the following features: uneven interstitial fibrosis and inflammatory infiltrate of lymphocytes, plasma cells, and occasionally neutrophils. Dilation or contraction of tubules with atrophy of the epithelial lining. Many of the dilated tubules contain pink to blue glassy-appearing PS-positive casts, known as colloid casts, that suggest that appearance of thyroid tissue, hence the descriptive term thyroidization. Often neutrophils are seen within the tubules. Chronic inflammatory cell infiltration and fibrosis involving calyceal mucosa and wall. Atherosclerosis may be caused by associated hypertension. Glomerulosclerosis that usually develops as a secondary process caused by nephron loss. Many patients with chronic pyelonephritis come to medical attention relatively late in the course of the disease because of the gradual onset of renal insufficiency or because signs of kidney disease are not noticed on routine laboratory tests. In other cases, the renal disease is heralded by the development of hypertension. The radiologic image is characteristic. Affected kidneys are symmetrically contracted with some degree of blunting and deformity of the calyceal system. On the picture you see the upper pole calyx that is stenotic, and this is shown by the arrow, with associated papillary necrosis. The adjacent calyx is fibrotic and distorted as well. The presence or absence of significant bacteria is not particularly helpful, as its absence does not rule out chronic pyelonephritis. If the disease is bilateral and progressive, tubular dysfunction leads to an inability to concentrate the urine, manifested by polyuria and nocturia. Chronic pyelonephritis usually is associated with urinary obstruction or reflux. It results in scarring of the pelvic calyceal system and the interstitium of the involved kidney and gradual progression of chronic kidney disease. Thank you for your attention.